There were two people came up with the exact, precise same question and wanted to know what is the relationship of localized nodular synovitis and a cyclops lesion. And there's probably histologically, they probably look very, very similar. There probably isn't a major difference histologically. There are a lot of theories as to why cyclops lesions develop. Some people believe the classic cyclops develops around a nidus that is represents some torn, retracted ligament fibers. And maybe they're left in at the time of ACL reconstruction, allowing a cyclops. It's of interest that cyclops lesions are described with ACL tears alone without reconstruction. That would be good for that theory. And they're also described with any procedure, like meniscal surgery. So I think histologically they are very, very similar. So I can't answer it any better than that. Okay, we're going to spend the next time dealing with cartilage. I will kind of give you an overview, but I will admit that the real expert in our group for articular cartilage will follow me. It is Christine Chung, and she will talk about some of the imaging procedures. But I've had an interest in bone and cartilage injury for a number of reasons. I've had an interest in trying to understand the biomechanics of what injury does to articular cartilage, and I've had an interest in the terminology that would be best used to describe the multitude of traumatic things we see, particularly around the knee, where many of us use different terms for this particular lesion or these lesions. And so during this talk, I'm going to introduce a terminology part, the terminology that I would like to use. You may or may not like it, but at least you will have been introduced to it. So a few general characteristics about articular cartilage that are well known to you. It serves as a shock absorber. And indeed, when you think about how much force is placed on articular cartilage during everyday activities, you can realize how much we need a shock absorber at the end of the bone. It's been estimated that even during normal activities, cartilage may be called upon to absorb in excess of 5 times the body weight. Now, as you're going to learn, cartilage is composed of a lot of water, and it is the pressurization of this interstitial fluid that serves as the force that protects the end of the bone. It absorbs the shock, and we will get into those characteristics in a little while. It is nourished mainly through synovial fluid that enters and leaves the articular cartilage with every movement that we take. So fluid is constantly moving in and out of the articular cartilage. The major constituents of articular cartilage are shown in this short table. And you'll see 3 columns. In the first one, collagen. In the second one, proteoglycan. And in the third column, I'm showing you water. And I'm comparing articular cartilage to other soft tissues, meniscus, nucleus propulsus, annulus fibrosus, bone, and fibrocartilage. I would call your attention to how much hydration there is within articular cartilage. 65 to 80% of the wet weight of articular cartilage is water. If we look at the dry weight in the upper figures here, 50 to 73% represents collagen, and 15 to 30% of the dry weight represents proteoglycan. So 3 major constituents within the cartilage. The proteoglycan content, and more about proteoglycan in a moment, is more concentrated at the base of the articular cartilage and not in the superficial layers. The opposite is true for the collagen. The collagen is more concentrated in the superficial or surface layers and not in the deep layers. Now, many investigators have studied the collagen composition of articular cartilage. And I'm sure many of you have read articles or even books on this subject, and you have seen this particular diagram over and over again, pointing out the classic description of the collagen within the articular cartilage. Often it is indicated that there are parallel collagen fibers within the surface, and then there are these very distinctive arcades of collagen described by Benninghoff that extend from the superficial layers down through the calcified cartilage layer being anchored into the bottom of the articular cartilage. There is a histologic phenomenon known as the tide mark that sweeps across the basal layers of the articular cartilage. Now, this is a good concept, and we're going to use it initially, but we're going to change it twice during the course of this particular lecture. Scattered among those collagen fibers are the chondrocytes. And much like the orientation of the collagen fibers, the shape and the size of the chondrocytes vary as we go from top to bottom. They are more shaped like an ellipsoid in the superficial layers. They become rounded and larger as we extend down into the deeper layers, and then they change shape again in the calcified layer. So the cells are certainly part of the story of the articular cartilage, as are the proteoglycans. These are large aggregate molecules, and this is what they look like. They have a core protein, glycosaminoglycan, often abbreviated GAG, that exist in these long, complicated side chains that are shown very nicely in this drawing. These side chains are charged negatively, and because of that, apparently create an osmotic pressure that becomes very important in the function of articular cartilage. So to simplify, which I like to do, if I think of healthy articular cartilage, I look at an aquarium that I have at home. And this is what the aquarium that I have kind of looks like. This is not my aquarium, okay? But I think it's like a healthy aquarium. We have the coral, which represents the collagen. We have the chondrocytes, which represent the fish swimming around my aquarium. And we have the proteoglycans and water representing the water in the aquarium. And when it is clear like this, it is healthy. Unfortunately, as we get older, our aquarium often looks like this, all right, which is what we are trying to prevent. Now, the classic description, returning to the collagen, is like this. It is a description of collagen framework that looks much like a Roman arch. And I mentioned this the other day, that this is the analogy that is constantly noted in the literature. So that is why I read about these arches. Now, what does a Roman arch do? Well, as a compressive force is placed on the top of an arch, it is transferred into a tensile force, trying to split these bricks apart. The construction of this arch is really done carefully, and you'll note the shape of these blocks on either side. So what occurs, these blocks eliminate all the tensile force that would really disrupt this arch and convert it back to a compressive force. So the eventual outcome of an arch-like structure is to take, in fact, a force applied to the superior surface, change its direction, and then redirect it as a compressive force along the sides of the arch. So let's look what happens now if we apply a load to the articular surface. This is going to lead to compression of the articular cartilage and a change in orientation of the collagen bundles. You can see that that has occurred here as some of these collagen bundles are more horizontal. The reason this occurs is the interaction of the solid matrix and the fluid matrix, or water, that we've already talked about. The proteoglycans and the water can be found within the chambers between these compressed collagen fibers, shown here. With compression, there is an increase in the swelling pressure in the solid matrix and in the water. So water is expressed from the surface of the tissue, much as you might see in a sponge. This is a characteristic finding of normal articular cartilage. People have likened this to what is seen with an air tent. If you have an air tent, you have air that enters through an intake vent. It reaches a fan. The fan transfers the air under pressure. It exerts a force on the fabric of the tent that prevents collapse. With articular cartilage, we're talking about fluid, not air, as the pressurized substance. So it is the fluid in the articular cartilage acted upon by the proteoglycans, which serve as the fan, that lead to the forces that keep the collagen intact within articular cartilage. As the fluid is expressed from the surface of articular cartilage, it lubricates that articular cartilage. There are many theories as to exactly how this lubrication occurs, 6 major ones. I'm not going to talk about them. I only understand about 2 of the 6 theories. So let's go back now to see what happens as we have compressed the surface of articular cartilage. Now you can see that with compression on the surface, we are going to get increased swelling pressure in the chambers beneath the collagen, or between the collagen fibers, in this particular way. And this creates tensile force on the sides of each of these chambers. These forces are aligned parallel to the surface of the articular cartilage. Many of the collagen fibers become aligned along the force lines, so they become more horizontal or horizontal oblique. And therefore, with an axial compression load, compression of articular cartilage, abnormal tensile force develops and explains the patterns of collagen failure, much as we explain them in tendons and ligaments, as I will do so over the next few days. So this is the theory, how compressive force is converted into tensile force and can explain the patterns of collagen fiber. Now let's change for the first time this architecture of the collagen. If you look at it, there are some who believe it is not arch-like, but leaf-like, and that it looks more like this sort of appearance of multiple leaves piled on one another. And if we try to illustrate that, as I've tried to do here, it would look more like this. You would see this layered-like appearance of these arches of collagen that are described by Benninghoff. There is some convincing evidence in the literature that this is a more accurate representation of articular cartilage collagen. If we take an oblique section through this sort of arrangement, it would look very much like what is published in an article in the Journal of Bone and Joint Surgery. These are the leaf-like areas of the collagen fibers shown here. One of my previous fellows, Doug Goodwin, has said, you know, I think of articular cartilage much like the bristles of a brush. And I started to think about it, and I think, gee, he's probably onto something here. And the reason he does, he kind of pictures these arcades or bristles curving at the top. There still are these longitudinal flat fibers at the top, and you can imagine that if you push your hand on the top of a brush like this, how the bristles would bend. So that's, I think, a very interesting newer concept as to the real architecture of articular cartilage. And Doug Goodwin is well published in the literature on articular cartilage, and this is taken from one of his many articles. And you can see why he got this idea. As you look at these sections, you can see these arches of collagen fibers extending up to the surface and flattening out as they reach the surface. So we'll move on with this theory for a while, and then we're going to change it again. So how does collagen fail, and how does cartilage fail? So let's go ahead and take the two major forces that are applied to the surface of articular cartilage. Those forces are compression and they are shear. One of the ways in which the cartilage fails has been described as chondral delamination. So I took that term and I went to the dictionary because I've heard other people talk about lamellation and lamina and all this. So here are the definitions in the English language for some of these words. Lamination means arranging structures in layers. Lamellation sounds very, very similar, composed of laminae, which are thin plates or layers. Delamination is splitting apart into layers or lamina. There is no word delamellation. So as I look at this and I'm trying to figure out what is the proper word to describe disruption of a layered-like tissue, without question, in my view, the proper word to use for this process is delamination. And that is the most popular word that you will come across in the literature. With regard to tendons and with regard to ligaments, delamination indicates failure along the long axis of the collagen bundles. With regard to articular cartilage, delamination has been applied to processes that are not parallel to the collagen fibers of the articular cartilage, which seems in my mind to be incorrect. And one of the reasons they have difficulty when they analyze cartilage, I've already shown you. These are curving structures as opposed to longitudinal collagen fibers in tendons and longitudinal collagen fibers in ligaments. So chondral delamination is a pattern of cartilage failure with an injury vector that separates either layers of articular cartilage, the collagen, or articular cartilage from subchondral bone. Now, these are the patterns that have been described in the literature as delamination. But if we go back to our original collagen framework and we look at some of these patterns, we can see we have a problem. This pattern certainly is not going parallel to collagen fibers and is not properly called delamination. This, in a mid-zonal area, is likely not going parallel to collagen fibers and should not be called cartilage delamination. True chondral delamination in its purest form is a separation of the articular cartilage from the subchondral bone. And we clearly see that, all right? Here's a beautiful example of what that looks like. The articular cartilage here is separated a long segment from that subchondral bone. Now, this is of interest in this case in particular because this is hyperparathyroidism. We all recognize hyperparathyroidism as a cause of subperiosteal bone resorption, but it's also a cause of subchondral bone resorption. Think of the widening of the sacroiliac joints, or the widening of the symphysis pubis, or of the acromioclavicular joint that you see in patients with primary or secondary hyperparathyroidism. That's not subperiosteal, that's subchondral. So in this particular case, extensive chondral delamination related to subchondral bone resorption at the junction of cartilage and subchondral bone. A force is applied to the articular cartilage, a compressive or shear force. This may be transferred in direction, as shown here, occurring at right angles to these longitudinal bundles at the surface of the articular cartilage. These are called armor plate bundles. If that is the case, they will be converted. They cannot go further in that particular direction because of these collagen bundles. So the pattern of failure that we're going to see at the surface of articular cartilage typically will be parallel to those surface collagen fibers. That's shown beautifully in an article by Peter Bulla, a very well-known pathologist. Here, a coronal section showing you as this goes down deeper, it would look like this, and here's the transverse section. This is surface delamination of articular cartilage. It meets all of the criteria. It is failure along the long axis of the surface collagen. Now, if we use this second theory, we can see, in fact, that the initial lesions will parallel the surface layer, and then they can extend down deeper and deeper parallel to these areas of collagen. So that is why a coronal image of a cleft, shown here, has this particular shape. So this is the typical pattern that we see in articular cartilage. We see it often. This is actually delamination, very different from the horizontal lines that we see. All right, so these are fissures, and fissures that we describe all the time occurring in articular cartilage are delaminated lesions of the surface articular cartilage. Here's what they look like. This is delamination, not horizontal defects, but these vertical defects that come in from the surface of articular cartilage. And they may become extreme and extend down to the junction of the cartilage and the subchondral bone. Here's an example where we can see the fissures that are extending vertically from the surface and then turn horizontally at the junction of the articular cartilage and subchondral bone. Both of these are patterns of true chondral delamination. And we see this kind of pattern all the time. Here's another example. Here we have the classic delamination, separating the articular cartilage from the subchondral bone plate. So it's beautifully shown in this example. This is chondral non-delamination. So when you see these areas of fissuring, or I should really tearing, that are oriented horizontally in the mid-zone of articular cartilage, in my view, in no way should you call these delaminated lesions of articular cartilage. They are not. These are at right angles in large part to these collagen bundles. This is chondral delamination and non-delamination. Here comes a lesion as a fissure from the surface articular cartilage, changing directions, now going through collagen and exiting as a fissure. And it would look something like this. So this is a tear of articular cartilage that has both delaminated features and non-delaminated features. We make our final change in the orientation of the collagen because when you really look at it, as opposed to the second theory, the distribution is more haphazard in multiple directions, as I show you here. So I started to think about, what does this look like? The first thing I came up with is a shag rug, because this really looks like the fabric that you see within a shag rug. So that would be a good analogy as to the real nature of collagen articular cartilage. But I didn't stop there. I went outside and I said, well, you know, it looks a little bit like grass in a nice lawn that's kind of heading up and then in different directions spreads out. And I kept looking, and I even came up in my aquarium of a pattern of coral, soft coral, that kind of looks like it. So my view of the collagen of articular cartilage is like this. It's not the arches that we saw described by Benninghoff. It's not exactly what Doug Goodwin said really look like the bristles of a brush. I think it is neither of those. What it really is a shag rug appearance, a grass appearance, or a soft coral appearance. And I think when we analyze these articular cartilage, we are going to have to think of delamination and non-delamination in terms of this collagen framework. So here is my picture of 3-dimension of the collagen framework, and I've drawn in on this framework a lesion of the articular cartilage. Now let's look at it. This is what it would look like in a section done in this axis, and this is reproduced in the literature. That's what I would expect. Let's change our assessment to one oriented along the long axis of this lesion, and you can find evidence of this pattern of failure within the literature. So in a way, all we need to do is think of much like painting. And what we try to do is to paint the tear on our collagen framework. And this is the kind of tear, and this is how it is painted on our collagen framework. It makes sense. Tears have to be governed by the framework of the collagen within the articular cartilage. Now that's just half the story, because sitting below the articular cartilage, we have the subchondral bone. And as the articular surface is compressed, it produces forces in the subchondral bone. Those forces are resisted by the trabecular pattern within the subchondral bone. So we go ahead and take away part of it, and this is what the trabecular pattern looks like in a lot of bones. Humeral head, femoral head, you have kind of intersecting lines of trabeculae. And you can see how the forces are transferred along this collagen framework. But we have another component as well within the ends of the bone and elsewhere, and that is the fat. So when we talk about the distribution of force and how it is picked up by the bone after it gets through articular cartilage, we have to consider not only the framework of the trabeculae, but also the fat between the chambers. This fat is compressed as well. The pressure in each of these compressed fatty chambers elevates when a compressive or shear force is applied to the surface. That tensile force is applied to the walls of the chamber. All right, that's what occurs, increasing the pressure within each of the chambers. In a way, it's like a tire. All right, you think of the situation of a tire. You apply a load at the top and bottom of a tire. It pressurizes the air within the tire, which places a greater tensile load on the side walls of the tire. The same thing is happening within these trabecular compartments at the end of the bone. If the tensile force placed on the walls of the chamber is greater than the tensile strength of the trabeculae, microfractures develop. These are the bone contusions. We're going to be talking more about those in a few minutes. The size and intensity of the bone contusion that is formed is influenced by the precise type of force that is applied to the articular surface. There are 3 such forces that may occur. Compression forces are straight vertical forces or impaction forces. The degree of pressure and hence bone contusion that occurs with this pattern of force is the greatest. Here is an example of a compression force that led to depression of the subchondral bone plate and a large bone contusion. The second type of force is a shear force. This is a rotational force that produces a force angulated with respect to the surface of articular cartilage. Marrow edema is produced, but it is not to the same degree as a compression force. The third type of force is a tensile force. This is typically applied where tendons or ligaments attach. Typically, we don't think of tensile force injuring cartilage or subchondral bone. But if in fact, as in the knee, we go ahead and take a very strong ligament, like a cruciate ligament, attaching to the intercondylar eminence of the tibia, we place a very strong force on that ligament, we can pull away portions of the articular cartilage along with the bone. And we do see this clinically, as in this example. This is a large avulsion of the intercondylar eminence of the tibia, produced by the attachment site of the anterior cruciate ligament. Note how this fracture extends over to involve the chondral surface of the tibia. Here, by the way, in association is a Sagan fracture. Tensile forces are associated with minimal marrow edema. So a great deal of marrow edema with compressive forces, less with shear forces, sometimes none with tensile force. The fractures we miss are the avulsion fractures. Those are the ones we miss on MR unless we have a plain film to help us. So let's return to chondral and osteochondral injuries about the knee. They may occur in an isolated fashion or be associated with problems in other structures in the knee. The preoperative diagnosis of an osteochondral or chondral injury can be difficult. One of the findings that is stressed by some orthopedic surgeons, the presence of a hemarthrosis without instability, suggests an osteochondral fracture. In terms of the location of chondral and osteochondral injuries of the knee, they've been reported, as you can see, in over half of arthroscopies. They are said to be most common in the medial femoral condyle as opposed to other areas of the knee, and they can range in size from very small to very large. The description of injuries of articular cartilage, there are several systems. One of the arthroscopic classification systems was developed by Outerbridge. I'm not going to go into any detail about this. A second was developed by the International Cartilage Repair Society. Perhaps Christine will be talking about their classification system. And there are even MR imaging classification systems in the literature. Two popular ones described by Biswell and one by Berdella now a few years ago. Okay, we've reached the halfway point, and now we come to terminology. And this is very difficult to come up with a uniform terminology for all these traumatic lesions. So here are some of the terms that you might consider. Chondral fracture, chondral injury. Osteochondral fracture, osteochondral injury, osteochondral defect. My favorite, osteochondral lesion. More about that in a minute. Osteochondritis dissecans and bone contusion. I'm curious, how many of you use osteochondral lesion? 1. Osteochondral defect? 10. Osteochondral fracture? 1, 2, 3, 4. Chondral fracture? 1. Osteochondritis dissecans. How many of you use that term? Okay, well, I imagine we all use these terms differently because there's no real agreement. So I'm going to introduce a system that works for me. I try to teach it to the fellows as we look at these cases. You may not like this system. Let's get rid of one of these right away. An osteochondral lesion, to me, could be anything. All right, I mean, it could be a chondroblastoma. And so I illustrate. It could be a giant cell tumor. So if you're dealing with a post-traumatic abnormality, get rid of osteochondral lesion because the orthopedic surgeon may think you're describing a tumor. So we're going to get rid of that one. One other point about terminology, and this is a real sticking point, but it is a very important point. A cortex is defined as compact bone formed by the periosteal membrane, intramembranous bone formation. That's a cortex, okay? This is not a cortex. It is compact bone, but it is formed by articular cartilage. That is called a subchondral bone plate. So when it is depressed, it is not depression of the cortex. It is depression of the subchondral bone plate, compact bone. And this takes on clinical meaning. Here's an example, a classic example of a lateral patellar dislocation with some of the bone injuries that you will see. This fracture is a fracture involving cortex. The abnormalities that you may see involving the weight-bearing surface of the lateral femoral condyle or the medial aspect of the patella relate to bone plates and cartilage. Those are chondral and osteochondral injuries. So you have to distinguish bone plates from cortex because they have great differences in clinical meaning and significance. Let's define a chondral or osteochondral injury in the following way. First of all, it typically relates to a compression or shear force, rarely tensile force. Most of the time, it's a force that contacts the surface of articular cartilage. The definition of a chondral injury is a force that is dissipated in the articular cartilage and does not reach the subchondral bone. The definition of an osteochondral injury is a force that's dissipated both in articular cartilage and in the subchondral bone. A chondral fracture is defined as a fracture line that is isolated to articular cartilage that does not extend through the subchondral bone plate. It may or may not be associated with something going on in the subchondral bone, a contusion or a fracture, but the chondral fracture itself is isolated to articular cartilage. Several patterns occur, depends upon the depth of the cartilage injury. So here is a chondral fracture, okay, with a chondral defect, which means something missing, but this is an osteochondral injury because there is something going on in the subchondral bone. So I would describe this as an osteochondral injury associated with a chondral fracture producing a defect in articular cartilage, measuring whatever, and with a bone contusion within the subchondral bone. The most common word I use to describe all of these things is osteochondral injury, because the vast majority of things that impact the end of the bone will have some effect in the subchondral bone. By the way, the sharp margins are very, very characteristic of traumatic lesions as opposed to, that's a bad word, traumatic fractures as opposed to degenerative changes within the articular cartilage. An osteochondral fracture is defined as a fracture that extends through the articular cartilage, violates the subchondral bone plate, and extends as a fracture into the subchondral bone in a continuous fashion. Now, several patterns exist because related to whether or not this fracture later exits the articular cartilage with a reverse pattern. This is an osteochondral fracture. Here's a nice example of what it looks like histologically. This was an interesting case shown at one of our conferences not too long ago. This is a classic osteochondral fracture, but it was kind of interesting how it was a coronal-oriented fracture of a single condyle, and these can be very, very difficult to see on plain films, particularly on the lateral radiograph. Osteochondral fractures are associated with chondral and osseous defects, missing tissue. And therefore, whenever you have them, you have to, in fact, look elsewhere for intra-articular bodies. Here's an example of one that has migrated. Osteochondral fractures, when compared to chondral fractures, show some differences. Osteochondral fractures more common in adolescents, chondral fractures in adults. Osteochondral fractures produce fatty and bloody effusions. Chondral fractures, no bloody effusion. Osteochondral fractures are radiographically visible. If the bone component is large, chondral fractures are invisible. And once the bone is violated, the healing potential improves, better for an osteochondral fracture than a chondral fracture. Osteochondral fractures are those associated with release of fat. The classic pattern, of course, is a lipohemarthrosis. The classic appearance of a lipohemarthrosis are the fluid levels that we see, often as many as 2 levels, 3 layers. Fat, we see blood, and then we see the cellular component. So when you find a lipohemarthrosis, you should suspect an osteochondral fracture. Sometimes, rather than a fluid level, you get bubbles of fat that are released into the joint. These typically float up to the superficial surface of the effusion. This has the same significance. This is a lipohemarthrosis, and you should be looking for an osteochondral fracture. Now, we see some interesting variations of this pattern. Here, a recent case that was sent to me, the patient did have a lipohemarthrosis, but look at the fluid level that has developed also within the fractured bone. A subchondral bone contusion is defined as a trabecular microfracture or infraction, which is another word, with hemorrhage and edema. I think it's more than that, but without a macrofracture. Most subchondral bone contusions, and I emphasize subchondral, right below the articular cartilage, when they occur in a bone, especially a long bone, relate to a force that began on the surface of articular cartilage and went through the cartilage. Now, I'm going to return to this point later in the course when we talk about bone contusions in a little more detail. But when you see something wrong in the subchondral bone following an injury, in a long tubular bone in particular, typically the force came through the articular cartilage, but it reached the subchondral bone and has produced a contusion. These have very, very characteristic appearances, but they're complicated, and I've always had an interest in the appearance. We're told that they kind of look serpentine-like, speckled. Okay, obviously areas of edema brighten up on the fluid sensitive, but when you look at this, it looks more than just blood. And it's our feeling, several of the faculty here, that there are components of fat here. There's actually lysis and necrosis of fat that make up the appearance of a bone contusion. Look at this. This is something now that we are seeing. These, in fact, are areas or regions of lysis and liquefaction of fat. The fracture is here, but we are liquefying fat a little bit away from that fracture. This is a common finding that you see particularly following greater tuberosity fractures, as in this case. So we think lysis of fat is part of what makes up bone contusions in general, and sometimes these can look really troublesome and almost look like another process is going on. If you identify extruded fat following an injury to the subchondral bone, as shown here, and as the dark signal here, and as the dark signal here on a transverse image, you have a fracture, because the fat has gotten out from the marrow cavity through the defect within the bone. So it is. Now, what are the differential diagnoses of a bone contusion? Early stages of osteonecrosis. I mentioned this earlier. You don't have the characteristic appearance that you see later on. So you can get patchy areas of altered marrow signal that without a history you may mistake as a bone contusion. Later on, we get the very organized appearance of bone infarct or osteonecrosis, enclosed fat, and a kind of a serpentine-like border to the lesion. Fat necrosis, different than bone necrosis. This is something we don't see often. It's sometimes described in patients who have pancreatic disease, pancreatitis, pancreatic carcinoma. It's described in actually battered children who develop traumatic pancreatitis. It's described in paniculitis, the syndromes where you get fat necrosis. Here's an example of what fat necrosis looks like in a tubular bone, and this could simulate a bone contusion if you didn't have a history. Certain normal variants, like prominent vessels, particularly in children, adolescents, teenagers, and young adults, can look like marrow edema and a bone contusion. And I've already mentioned that chronic overuse syndrome that we see in the foot and ankle can look like bone contusions, but they're probably stress-related. And certainly even osteoarthritis leads to marrow alterations that can simulate bone contusions. We move on to a subchondral fracture. This is defined as a fracture that extends through the subchondral bone in a linear or curvilinear fashion without violation or depression of the subchondral bone plate. Several patterns exist related to whether or not the fracture line violates the cortex of the bone or extends into the subjacent bone. Subchondral fractures in long tubular bones, when located immediately below the articular cartilage, almost universally relate to a force, compression, or shear applied to the end of the bone, okay? So a subchondral fracture in almost all cases is a manifestation of an osteochondral injury. You may not see any effects in the cartilage, but it was injured. The force came through the articular cartilage to reach the subchondral bone. These are what they look like. This is a subchondral fracture with marrow edema. It's a manifestation of an osteochondral injury. It is difficult to predict the later development of articular cartilage abnormalities in the presence of contusions or fractures in the subchondral bone. You all have seen this. You see something in the subchondral bone, a contusion or a fracture, and the articular cartilage on MRI looks normal. It may look normal on arthroscopy as well. There are probably at least some biochemical alterations going on. The MRI shows the marrow changes. In general, based on the cases I have seen, and I don't have a lot of experience with follow-up, but on the few that I do, the presence of a subchondral fracture line carries a worse prognosis than a bone contusion with regard to the later development of articular cartilage abnormalities. And I'll show you one, the nicest example I've seen. It is this one, the time of injury. We saw a fracture line in the subchondral bone. There may have been slight depression of the subchondral bone plate. 6 months later, there is a clear chondral defect at the site of injury. So in my view, if it looks like a fracture line in the subchondral bone, I think the prognosis is a little bit worse. I don't think there are any great studies on that particular subject, though. The differential diagnosis of a subchondral fracture, a stress fracture. These do occur in the subchondral bone. We've already talked about them, for example, in SONC and other things like that. SONC itself, shown here, which I just talked about in the prior lecture. These are insufficiency fractures, but without a history. You might say this is an acute subchondral fracture. Laser and heat necrosis. You know, they use lasers during arthroscopic surgery. They create heat. It injures the subchondral bone. This is a characteristic pattern. It's kind of a curvilinear line within the subchondral bone. It looks a lot like a subchondral fracture or even an osteochondral fracture. Consider laser heat necrosis. And in the same fashion, look at this case. This comes from Taiwan. This was a patient who went to a spa and had repeated treatments of very, very hot towels applied to the knee. And this is heat necrosis of bone. The skin was also grossly abnormal, I might add, but look how all these are on the surface of the bone. That gives you some idea that the insult came from the outside in. So this is heat necrosis. And some forms of osteonecrosis may simulate a subchondral fracture. This is steroid-induced osteonecrosis of the patella. But if you did not have a history, you could easily say this is a subchondral fracture or an osteochondral fracture. So let's look at a few case studies. In this example, I think that the best description would be that this is an osteochondral injury that is manifest as a subchondral fracture. That's how I would describe this particular case. A second case. This is an osteochondral injury manifest as an osteochondral fracture with depression of the subchondral bone plate by whatever, and it would measure it and try to figure that out. Or another one. This is an osteochondral injury manifest as a chondral fracture and defect and a subchondral bone contusion. The subchondral bone plate is intact. And another one. This is a chondral injury manifest as a chondral fracture and a chondral defect, measuring whatever, all right? That's how I think that these should be described. We'll finish up in the last 10 minutes by addressing a couple of other points. Osteochondritis dissecans. I discussed this in a little detail the other day. Most people regard this as a chronic stage of an injury. Now, whether the initial injury was an acute event or this was repetitive injury could be debated, but it's defined as a subacute or chronic lesion of the subchondral bone plate and subjacent bone that in many cases is related to a repetitive stress injury or the later stage of an acute single traumatic event. Although there is some evidence in the literature that there are some cases that are ischemic in etiology. The integrity of the overlying cartilage is variable. The second most common site that we see osteochondritis dissecans in the human body is the knee. The talus is number 1, this is number 2. The classic pattern, the inner aspect of the medial femoral condyle. Extended classic pattern, it goes further over onto the weight-bearing surface. On the lateral side, less common, a couple of patterns. This is a weight-bearing pattern where a large segment is involved. In my experience, when you see this on the lateral side, it tends to be larger than on the medial side. The other pattern on the lateral side occurs anteriorly, probably related to shifts of the patella, where you shear off in a single event or multiple events a portion of the articular cartilage and subchondral bone plate. When we go ahead and look at osteochondritis dissecans, orthopedic surgeons use the term stable or unstable. This would be kind of a stable-looking lesion. There's no depression of the articular surface. There is no large gap between the cartilage and bone fragment and the parent bone. This might be one you would say is unstable because indeed there's a large gap, there is surface irregularity. So that may be a way that you could consider it. Orthopedic surgeons might use the approach arthroscopy and see what the effect is when they push on this. And if there's no effect, they may call it stable, as opposed to when they push on it, depressing the fragment, they might call that unstable. To a radiologist, I think we use something different. We look not only at the surface of articular cartilage, we try to decide whether or not fluid is dissecting down between the fragment and the surrounding bone. If in fact we see no fluid down there, we will say it is stable. If indeed we see fluid going down into that interface, we often regard it as unstable. That fluid could be a native joint effusion, or it could be during an arthrogram, a contrast agent. Here's an example of unstable focus of osteochondritis dissecans with native fluid escaping and extending downward, filling the gap between the fragment and the parent bone. Here is CT arthrography and MR arthrography showing you the same effects with contrast agent dissecting down into that interface. The differential diagnosis of osteochondritis dissecans includes, among other things, the normal irregular ossification pattern that involves the posterior aspect of the femoral condyles. Note how the articular cartilage looks normal. neuropathic osteoarthropathy, which can lead to bizarre lesions and fractures and depressions at the end of the bone. This was in a young person who had congenital insensitivity to pain. And then finally, extra-articular fractures, defined as fractures that are entirely or almost entirely extra-articular, whether they extend fully or partially across the bone. Now, many of these injuries, not all, are related to an external force, not to a force that came through the articular cartilage. So the further away from the end of the bone that you see these fractures, the more likely they have nothing to do with an injury to the end of the bone. There are 4 mechanisms that lead to these fractures: tension, compression, bending, and torsion. Tensile leads to a pulling apart and a transverse fracture line. Compression leads to an oblique fracture line. Bending leads to an oblique fracture line with a butterfly fragment at the point of force input. So whenever you see a butterfly fragment, that's where the force entered the bone. It's not on the opposite side. It's where the force came in. And then torsion, which leads to, in fact, these spiral type of fractures. Here is an extra-articular fracture. This one does go through cortex, not subchondral bone plate. It is located at a distance, most likely related to an external force. And one other point about these extra-articular fractures, some of them are not complete. That is, they don't go from one side of the bone to the other. Perhaps we should call those extra-articular infractions. The definition of an infraction is an incomplete fracture. You all have seen this, I'm sure, with the greater trochanter fractures that begin to extend across the bone, maybe halfway, maybe even beyond that, but don't reach the opposite side. So these are not completed fractures, but incomplete fractures.